Hola. Thank you everyone for having me. It is my absolute honor to be here at Médica today and talking to you all about something that's very dear to my heart, which is headache and migraine. I'm very grateful to my colleagues here at Médica for the invitation to come and speak. So these are my disclosures, and these are the learning objectives for the next 30 minutes. We will discuss a systematic approach to arriving at a correct headache diagnosis, identify that a migraine attack is a complex neurological event that involves the interaction between peripheral and the central nervous system. We'll be able to explain how brain regions are activated before, during, and after headache within a migraine attack. And then finally, identify new treatment mechanisms in migraine that are now based on migraine pathophysiology. Migraine can be, or headache actually, can be a very complex problem. There are over 300 causes of headache outlined in the International Classification of Headache Disorders, the latest version of which was just published in January 2018. Having said that, I think sometimes it can be very complicated and a little daunting when a patient comes in with headache and we're trying to find the right diagnosis. I'm hoping that in the next 30 minutes I'll be able to provide you the systematic approach to tackling that problem. So when a patient comes to see you with a complaint of headache, our first job as doctors is to distinguish, do they have a primary headache disorder like migraine or something related, or is the headache a symptom of some other problem? And we can do that by taking a very detailed history and exam. If there are any red flags in their history or any abnormalities in their exam, we then need to go on and do a thorough evaluation looking for potential secondary causes of headache. If they do not have any red flags, and we'll talk in a minute of what those can be, we can diagnose the patient with a primary headache disorder based on their symptoms. However, if they have any atypical or unusual features, we then need to go back and do an evaluation for a secondary cause. I like this mnemonic. This is something that Dr. Dodick taught me when I was a trainee. The mnemonic is snoop for red flags. I think about this mnemonic every time I see a patient and use this with my questions. So the S stands for any systemic symptoms, signs, or disease. Does the patient have any fever, weight loss, history of malignancy, and is now coming in with a headache problem? If so, the headache could be a symptom of some underlying problem. The N stands for any focal neurologic symptoms or signs. So this is where a careful neurological exam is very important. With all of my patients who come in with headache, I'll do a fundoscopic exam, for example, looking for signs of papilledema. There are two O's. The first O stands for onset. And we'll talk about this in much more detail tomorrow. But really what we're wondering is whether a patient came in with a thunderclap headache, meaning they had the abrupt onset, worst headache of their life with the pain reaching peak intensity within 60 seconds. If so, they might have a serious underlying cause. The other O stands for older age of onset. So we know that many primary headache conditions can occur later in life, but also later in life, secondary headaches also become more common. So if a patient comes in with a new onset headache and they're a little bit older, we'd have a higher index of suspicion that there might be something else going on. And then there are 4 P's, which stand for pattern change, precipitation by Valsalva, postural, and pregnancy. So if a patient has a history of episodic headaches and now what they're coming in with is completely different, that's a pattern change and should be a red flag. If the headache is precipitated by Valsalva, that's also a red flag. We know that migraine and other primary headache conditions can be worsened with exertion, but this idea that the headache is triggered by exertion or Valsalva is a cause that there might be something else at play. And then if they have a positional headache, meaning the headache is brought on by lying flat or being upright, it might be a problem with spinal fluid pressure. And then finally, in the pregnancy and postpartum period, these women are at higher risk for a potential secondary cause, and we need to be a little more careful there as well. So when a patient comes in with a new onset headache, it's all about the details of the history. I will spend a lot of time asking them questions about their history, about their headache, and by the end of that portion of their evaluation, I typically have a pretty good idea of what's going on, and I'll use my physical exam to confirm my suspicions. If the patient has any potential red flags in their history or exam, I will then proceed to do additional tests, which may consist of neuroimaging, blood work, or even a CSF exam looking at opening pressure. A quick note on neuroimaging. When you think about all the potential secondary causes of headache, that list is extensive. So if you're thinking about getting a neuroimaging on your patient, think about getting an MRI scan. A CT scan is never going to be sufficient to exclude all these potential secondary causes. Once you've excluded secondary causes of headache, the next thing to do is to sort out what your patient's headache diagnosis truly is. And you can do this by asking a next set of questions. My next questions really have to do with their headache frequency and their duration. So I'll ask them, how often do you get headaches? And then when you get a headache, how long does the pain last? Based on their answers, we can divide their headache up into a few different potential categories. So there are headaches that are short duration and infrequent or frequent. If they're short duration, your differential would be different than if they have a long duration but infrequent headache. And when we're talking about short and long duration, the differential is 4 hours. So less than 4 hours or longer than 4 hours. And then if they have a chronic daily headache, and we'll talk about this in much more detail, but essentially long duration headaches lasting more than 4 hours and occurring more than 15 days per month, your differential will be a little different there as well. So for these short duration headaches, you'll be thinking about things like cluster headache or other rare headache conditions like hypnic headache, primary stabbing headache. There's a very long list of possibilities. If the patient has a recurrent headache of long duration, but it's less than 15 days per month, they probably have migraine or tension type headache. And if they have a chronic daily headache or headaches that occur longer than 4 hours and are present most days out of the month, most likely what they have is chronic migraine. There are some other possibilities as well, including chronic tension type headache. We know migraine is very common. Epidemiology studies have told us that at least 1 in 4 households has a member with migraine. And personally, I think that number is actually an underestimate. Every day in clinic, I'm sharing with a patient that they have migraine, and they were completely unaware of that because they had an idea that migraine was something different than their headache. And if you think about it, if you think about patients that you might see who say, oh, I've got headaches, but with their headaches, they need to go lie down in a dark, quiet room, or maybe they have some nausea, or they can't function the way they like to do. Maybe what they truly have is migraine, so this number could be an underestimate. Regardless, we do know that in the world today, there are at least 1 billion people who suffer from migraine, so this is a global health issue. Migraine is often misdiagnosed, and most commonly, it's misdiagnosed as either tension type headache or sinus headache. And I think there's a few reasons for this. Migraine is often misdiagnosed as sinus headache by my patients, and when I ask them, why do you think it's a sinus headache, they'll tell me, because the pain is right here, or because the weather will trigger my headaches, or because when I get a headache, I feel a little bit congested. The truth is, though, all of those features that I just named do not differentiate sinus headache from migraine. And if what the patient has is a recurrent headache pattern with those symptoms, and they don't have an acute sinusitis, probably what it is migraine. The vast majority of the time when patients tell you they have sinus headache, what they really have is actually migraine. And migraine is also very commonly misdiagnosed for tension headache. Patients will tell me, doctor, I have tension headache, and that's because I have a lot of neck pain with my headaches, or it's brought on by stress, or my headache is on both sides, and I thought migraine is only supposed to happen on one side of my head. And again, those features do not distinguish between migraine and tension headache. In fact, neck pain is very common in patients with migraine. And we know that because of the migraine pathophysiology. We think of migraine as being a neuronal disorder with inputs from the cervical spine. So, neck pain is actually one of the most common associated symptoms of migraine, which is what I just explained here. So that trigeminal nucleus caudalis is continuous with these cervical segments, and so neck pain occurs very frequently in patients with migraine. Given that I've told you that, migraine is so common and potentially, underdiagnosed and often mistaken for tension-type headache, I think it's really important to review the actual diagnostic characteristics and the diagnostic criteria for both of these so we can look at the differences a little bit. So for tension headache, patients need to have at least 10 episodes fulfilling the following criteria, and for migraine, they need to have at least 5 attacks. And this is all the updated diagnostic criteria I just published in January of this year from the International Classification of Headache Disorders. And then the duration is also a little bit different as well. This is duration without treatment. So if a headache is left untreated, tension headache can last anywhere from 30 minutes up to 7 days. However, with migraine, per the diagnostic criteria, these attacks will last anywhere from 4 hours up to 72 hours. So it's a little bit of a tighter time frame. And then with the next set of criteria, so with migraine, the patients need to have at least 2 of the following features with their headaches. It's more intense on one side, it may throb or pulsate, it's moderate to severe in intensity, and it's worse with activity. They only need 2 of those, and about 40% of patients with migraine actually have bilateral pain. You can think of tension headache as the exact opposite. So it's typically bilateral, mild to moderate, non-pulsating, and not worsened with any activity at all. With migraine, patients also need to have one additional symptom. Either they have nausea or lights and sounds can bother them. And sometimes it takes asking the question a few different ways to tease out that symptom. So I was talking with one of my colleagues last week in clinic about a patient who we thought had migraine, but when we asked, "Are you sensitive to light and sound?" the patient said no. We went back and asked, "When you have a migraine, do you feel more comfortable if the lights are dimmed or the room is a little quieter?" And she said yes at that point. So I think sometimes it takes asking the question a few different ways to really, clarify the symptoms. And really, tension headache is a diagnosis of exclusion. If you can make the diagnosis of migraine, that's probably what they have. And of course, with all of these primary headache conditions, you have to have excluded a secondary cause first. If you don't have time to ask all of those questions, ask at least 3. The mnemonic here is pin the diagnosis. So ask about photophobia or light sensitivity. Does light bother you when you have a headache? The I stands for impairment or disability. Have you been disabled by a headache sometime in the last 3 months? And the N stands for nausea. Do you have nausea with your headaches? If patients say yes to at least 2 of these and they have a recurrent ongoing headache picture, probably what they have is migraine. There's a 93% positive predictive value. If they say yes to all 3 questions, that positive predictive value is almost 100%. We talked a little while ago about chronic daily headache. So chronic daily headache in and of itself is not a diagnosis. All it tells us is that this patient has headaches at least 15 days per month, with each headache attack lasting at least 4 hours, or they have continuous headache pain. The next step is to differentiate between the following possibilities to really hone in on what the accurate diagnosis is. So if the patient has chronic daily headache and their headaches meet migraine criteria at least 8 days per month, or they take a medicine to stop it from reaching that level at least 8 days per month, what they have is chronic migraine. If the patient has a side-locked headache, so the pain only affects half of the head, never crosses the midline, and they have some ipsilateral cranial autonomic features with that headache, then what they might have is something called hemicrania continua. New daily persistent headache is an unusual headache diagnosis. The defining feature of that is that patients will remember with crystal clarity the moment their headache began. So if I go in to see a patient and I say, "Tell me about your headaches," and the first sentence they share is, "Well, doctor, it was November 5th, 2008, about 2 o'clock in the afternoon. I was sitting at my desk and this headache started." If they can remember with that kind of clarity at the moment their pain started, most likely what they have is new daily persistent headache. And then chronic tension type headache is a diagnosis of exclusion. If you've been able to exclude all of these other possibilities, then that might be what you're left with. Out of this list, chronic migraine is the most common. And there are a number of different reasons why someone might go from an episodic headache pattern to something that meets criteria for chronic migraine. And these are all things I'll go through with my patients as well. So excessive caffeine intake. The thought is if someone's drinking more than 200 milligrams of caffeine per day, that might contribute to the maintenance of a daily headache picture in someone with migraine. So one of the first steps is to actually have them discontinue caffeine completely for a few months and see if that helps. Their baseline headache frequency, and we'll talk about this in a little while with my next talk about migraine prevention, because if a patient has a high baseline headache frequency and it's not treated appropriately, that headache can continue and develop into a daily picture. Similarly, medication overuse. So taking too much as needed medicine for headache can also lead to more frequent headaches over time. Being obese or overweight, having untreated sleep apnea, these are all things that we can address that might lead to some headache improvement as well. And if patients have comorbid anxiety, depression, or other pain disorders that are not treated, that can actually contribute to migraine worsening over time. Allodynia is an interesting symptom. So some patients, when they have migraine, they'll tell you that it really bothers them when they have a migraine attack to wear a hat or to wear glasses or earrings or pull their hair back in the ponytail. That non-noxious stimuli actually becomes painful. And the presence of cutaneous allodynia can be a marker that migraine is worsening over time as well. So medication overuse headache, I mentioned this previously. The ICHD defines this as a headache occurring at least 15 days per month in a patient with a pre-existing headache disorder, most often migraine. And during this time, they have been overusing their medications, and of course, you've excluded secondary causes as well. The ICHD actually has a whole section devoted just to medication overuse headache, where they define what medication overuse headache is for every single potential type of acute medication you can think of. But the bottom line is this: if your patient is using ergots, triptans, opioid analgesics, combination pills, or butalbital-containing medications, and they're using that more than 10 days per month, that can lead to more frequent headaches over time. If they're using non-opioid simple analgesics, so paracetamol or NSAIDs, that number is increased to 15 days per month. But if they're using multiple different classes of medication, their total exposure, if it's more than 10 days per month, can lead to more frequent headaches over time. All right, so with all of that in mind, it's also worth noting that we have a better understanding of what's going on with migraine now than we did, say, 10 years ago. We know that migraine is a complex, multifactorial, neurologic, genetic disorder, and we are constantly discovering new genes involved in migraine. There is this old theory of the vascular theory of migraine. So with this idea, the thought was that when patients have a migraine aura, there's constriction of vessels, and then when they have their headache, there's dilation of vessels, and then when you treat them with medicine, that leads to constriction of the vessels again and stops the migraine attack. And there have been numerous studies done that have completely disproven this. This is a false hypothesis and not what's going on at all. We know that it's more of a neuronal disorder, really a brain disorder, than a blood vessel disorder. When you think about the head and the brain, there are a number of different pain-sensitive structures, including extracranial structures like the eyes, the ears, the gums, the teeth, as well as the dura, vessels, and even cranial nerves and upper cervical spinal nerves can all be pain sensitive. So we think that headache is caused by inflammation, traction, or pressure on pain-sensitive cranial structures. And based on that, this is our current understanding of migraine pathophysiology. So at the heart of this is a sensitized trigeminal ganglion, which will obviously innervate meningeal blood vessels and the dura, and also synapse onto the trigeminal cervical complex, which also has input from these upper cervical nerve roots. We have these descending pain modulatory pathways that come down from the periaqueductal gray that can help to dampen the signal, but ultimately this pain signal is then transmitted to the thalamus and then spread across the brain throughout this pain matrix, which is very diffuse. And migraine attacks are not just, it's not just the headache pain that we're talking about. There's a whole sequence of things that can happen with these patients. Most patients will have a migraine prodrome, which happens even before the pain begins. And if you ask your patients, they might tell you that, I become very fatigued, or I start yawning quite a bit, or I'm already light and sound sensitive even though I don't have headache at that point. And that can last hours before the migraine attack even occurs. A minority of patients will then go on to have a migraine aura, which is defined by positive neurologic symptoms, most commonly visual symptoms, but can also include sensory symptoms and speech disturbance, lasting 5 to 60 minutes prior to the onset of headache pain. And then we have the headache that we just described, which is throbbing, moderate to severe, worsened with activity, with nausea, light and sound sensitivity, neck pain, cutaneous allodynia. And when that has all subsided, many patients will tell you that they have what they often refer to as a migraine hangover. So this is, they haven't fully recovered yet. They're still feeling quite fatigued and tired and maybe cognitively not back to baseline, and this can also last several hours or even up to a day. So, this is a question, but we'll just go through it. So the question that's been raised is the following brain regions may be activated during a migraine attack. Is it the hypothalamus, the thalamus, or the cortex? And the answer is actually it's all of the above. There have been multiple functional imaging studies that have shown us that during these different phases of migraine, different brain regions are activated. So during this premonitory phase, you can have activation of the hypothalamus, the brainstem, the cortex. Migraine aura is a cortical phenomenon. And then with the headache pain, the headache attack, you actually have diffuse involvement as well, and also with that postdrome. So this is a very diffuse process that encompasses essentially, pain pathways throughout the entire brain. And there has been some additional studies done on chronic migraine. So we know from these functional imaging studies that in patients who have chronic migraine, so again, more than 15 headache days per month, there's actually areas of reduced brain volume compared to healthy controls. And just recently, my colleagues at Mayo Clinic in our neuroimaging lab published a study where they compared the cortical thickness of patients who have chronic migraine to healthy controls, and they noticed a difference there too. So what these studies do is they really just add credibility that migraine truly is a brain disease. All right. Many patients will come to see us who have had either an MRI scan, or they'll ask us, doctor, you say I have migraine, do I need an MRI? A couple of things to mention. First of all, if your patient has migraine, there are no red flags, they actually do not need brain imaging. And then, if they have had brain imaging, you might see these non-specific T2 hyperintensities in the subcortical white matter on MRI. Patients always ask, what does this mean? And there have been some studies done looking at that very question. What we know is that they actually don't mean much of anything as far as we know. They don't lead to any changes in cognitive function or any increased risk of stroke. So we typically just tend to ignore them. So this is a very exciting time for me as a migraine specialist because we have some new treatments that are just coming out now based on our current understanding of migraine pathophysiology. With these trigeminal afferents, one of the things that's released is calcitonin gene-related peptide, and that has become a new treatment target for us. And also we have various non-invasive neuromodulation devices that we also use to modulate this whole pain pathway as well. So calcitonin gene-related peptide, or CGRP, this is a very potent vasodilator. It's released when the trigeminal ganglion is electrically stimulated or spontaneously during both migraine cluster attacks, and its release is blocked by sumatriptan. If you infuse a patient who has migraine with CGRP, you can actually trigger a migraine attack. And studies have also shown us that in patients with chronic migraine, their interictal levels, so their serum blood levels of CGRP between attacks is also increased, and that will improve when they're on appropriate treatment. So a few clinical pearls that I hope you take away from this talk. When you see a patient with migraine, remember it's not just the headache pain that they're talking about. You can ask them about any premonitory symptoms that they have, like difficulty concentrating and tiredness. It'll show that you really understand their disease. Patients will often also ask you about their neck pain, and you can assure them this is part of migraine based on your understanding of migraine pathophysiology. And if they don't have any red flags, they don't have an abnormal exam, they actually don't need imaging, and that neck pain should improve as you treat their migraine. Patients are always impressed when you ask them about allodynia. I typically ask them, when you have a migraine attack, do you find it uncomfortable to wear a hat or glasses or to have your hair pulled back in a tight ponytail? Patients are always impressed because it lets them know that we do understand about their disease process. So in summary, when you see a patient with headache, remember to snoop for red flags, so exclude potential secondary causes of headache, and to pin the diagnosis, ask about photophobia, impairment, and nausea. And remember that patients don't just have the headache pain, but they can have premonitory symptoms that can last hours prior to the headache coming on, and these post-stroke symptoms that are residual and can last after the headache has subsided as well. There are multiple brain regions involved in migraine, and these our understanding of migraine pathophysiology is leading to some new targeted treatments. So with that, I will conclude. Muchas gracias.